First, I want to thank all of you for your attendance. I want to thank the meeting organizers for inviting me and Livanova for sponsoring my talk. This is something that I'm pretty passionate about, and I've been a perfusionist for 35 years. So I've been practicing as a clinical perfusionist, but a big part of our practice has been autotransfusion. And so we started a program in 2013 in blood management at Memorial Hermann Healthcare Center, which is a hospital that I've been working at for decades and continue to practice part-time. So first, I'd just like to tell you, I don't think I have any conflicts of interest, but nothing to disclose, and any honorarium that I would receive, I will be donating to a nonprofit that's focused on research and education for cardiovascular heart disease. So why do we want to do this? What's the benefit for the patient? What's the benefit for us as clinicians? What's the benefit for our hospitals? And I'd like to talk to you about that for a few moments before we really get into what we did at Memorial Hermann and how we've set up our program. Just some focus points, just looking at what's good for you, but like everything that we do, we want to focus on what's best for our patients, what's safe practice for our patients, and always assessing risk-benefit. And this is something, like Ty said, we've always been told it's a contraindication, we can't do this, it's not safe. And Dr. Waters has done extensive research on this topic. And there's white paper out there, there's studies that show that we can actually do this and do it safely. So what's good for the patient? When I started doing this, I don't know a whole lot about, and there's probably people in the audience that know more about this than I do, and I certainly will welcome any input that you have so that we can continue to make our program better. But when we started kind of researching this, I was really astounded about how much blood was actually given to women during pregnancy. And it's pretty astounding that 6% of blood that's given is given in the maternal, for maternal patients. And that's a lot of blood. It's like 800,000 units of RBCs. Also, postpartum hemorrhage is a larger problem than anybody thought, and I certainly didn't realize, and it's the 5th leading cause of mortality in maternal deaths. And in 2000, the United Nations, the World Health Organization, and others started lots of goals. They're called the Millennial Development Goals, and one of them was to look at maternal and deaths worldwide and focused on all countries, but most especially in developing countries. And what was interesting was that in developed countries since that time, in the period between 2000 and 2015, in all developed countries, and this graph just shows you comparing several of the developed countries, of all of those, only the United States maternal deaths went up instead of going down. And I thought that was pretty significant, that in our country, actually maternal deaths have gotten worse instead of better. And I'm really not sure what the answer is, and in reading in the literature, it looks to be focused on women's age. Women are older, having children, more cesarean sections, and so this may be leading to why, but it's still, it's an interesting fact and something that needs to be addressed. So just looking at all the maternal deaths, this is a study done in North Carolina looking at maternal deaths, and the most preventable, obviously, from this slide is hemorrhage. And those are the 2 areas that as perfusionists we're probably going to be involved in are postpartum cardiomyopathies, and then obviously patients that would have hemorrhage, where you could get involved as far as getting into some blood management strategy. And in this study that was done in North Carolina, 93% of the patients' deaths were preventable from the hemorrhage, which is pretty significant given that if there was a way to actually save blood, give blood back. What impact would autologous blood salvage have in this patient population? So another reason that we got involved and why this is beneficial for the patient is in looking at, and we all know as perfusionists that our pregnant patients, their blood volumes increased. But when you think about the uterine blood flow, how much blood, it's massive blood flow per minute. So you're talking about almost a liter of blood per minute, 750 mils a minute. And so if you have sudden hemorrhage, how quickly a mother could bleed out during delivery. So it's pretty intense. And when you, just getting involved in this when we're in our practice, that's what we're seeing clinically. It's either minimal blood or a lot of blood, and a lot of blood very quickly. Just some statistics, the incidence of severe bleeding in childbirth is 1 in 200 to 250 deliveries, and in developed countries. And that's why this was a focus of the Millennial Development Goals, because of the, in developing countries, the obstetric bleedings and death from hemorrhage. And this is the biggest reason why we got involved, is even small amounts of blood, when you know you're going to have a high risk of hemorrhage, even small amounts of blood, can we make a difference or at least reduce the amount of allergenic blood these patients are getting? And so, and again, I'll talk about how we started our program, but this is one reason that our OB physicians wanted us to get involved and set up a program specifically for our high-risk OB patients. Additional hazards for your OB patients. These women are obviously younger. Transfusions may be more critical. We're all learning more about transfusion-related increase in morbidity, mortality in our cardiac patients, and this is also true in our female OB patients. Potential building of antibodies from receiving RBCs, and then if you need a transfusion later in life, these women later in life need transplants or devices. That may be one reason why our female patients are higher risk for when we do cardiac disease, transplants and when they have cardiac surgery. I don't know if that's true or not, but just thinking about maybe there's a correlation there. So, we're all talking about changes in healthcare, looking at strategies to improve what's going on as far as being of benefit to the hospitals, and thinking about how we can be cost effective. So looking at blood management strategies, I think perfusionists are getting involved and should be involved. And like Ty was saying, we were talking earlier about there was a real push for us to set up blood management strategy programs in the cardiac theater and in trauma and ortho, and it seems to have kind of leveled off, or in fact gone down. I work at Memorial Hermann's a level 1 trauma center, and we do quite a bit of trauma. However, we've actually decreased the amount of autotransfusion that we've used in that arena versus increasing, which is really interesting. So I think we need to all collectively think about how we can revitalize our blood management strategies. Also, I think that patients are becoming consumers more, and as results for our outcomes are public, that patients are going to start shopping, and they can make choices. And if you have a blood management strategy program, then that could possibly be a benefit for your institution, that may want, a patient may want to come to your institution versus another. A study by Dr. Waters also shows that it's actually affordable and it's actually cost effective to have a cell salvage program for this patient population. And I think this study was done over 10 years ago, so this actually may be a conservative amount, but over $100 savings for every unit of allergenic blood that you don't transfuse. This is a slide from a study that was done by our American board and presented at the AMSEC meeting, and it's published. And I think you can also find this on the American board website. But it's just showing, obviously, our procedures, how many cases perfusionists are pumping every year. And so and thinking about, taking on something else, another strategy, another program, how do we staff it? And for some of us, we may be in the period where we're doing less than 60 cases a year, 40 cases, but you still need, if you have one perfusionist, you need two. And I think that for us to be involved in other areas, especially blood management, just adds value for us at an institution. And so this is, having a blood management strategy program is a way that you can actually market yourself at your institution and saying, I need to keep my staff. I don't know if all of you have looked at this study, but it's really interesting as far as the work field and how many cases we're doing. So it's something for you to consider when you're setting up your program, how you're going to staff it. So for me, we were already doing blood salvage for the Jehovah's Witness patient, and I'm sure all of you do. If you have a Jehovah's Witness patient or a patient that's going to refuse blood transfusion, you're going to make that service available to them if you have it available in your hospital. Big study in Great Britain, Salvo Study, the literature shows that actually blood recovery in obstetrics is safe. Over 3,000 women were included in this study, and there were a single amniotic fluid embolism documented, so there were no transfusion-related events in this study, and that was with or without a leukocyte depleting filter. Studies by Dr. Waters, which Ty mentioned, several things that are included, that if you're going to do this, is to consider using a leukocyte depleting filter. Of course, the contraindication being a potential amniotic fluid embolus, and this is idiopathic. I don't think anybody really understands why this happens and how much amniotic fluid is necessary to cause an amniotic fluid transfusion anaphylactic reaction. However, it's tied to the squamous cells and the tissue factor, and so by utilizing a leukocyte depleting filter and washing thoroughly, you can get the level of the tissue factor that would be in the transfused blood back down to the level that would be in the maternal blood. So Dr. Waters' study shows that and recommends that you use a leukocyte depleting filter. I don't know if any of you have used this filter before, but if you do use it for autotransfusion, make sure that you prime it before you put blood in it, or you'll never get any blood out of it. So make sure that you wet it with saline first, because it does move slow through the filter. So is it effective using cell saving for obstetrics? The Salvo study included all patients, so it was all over the board as far as whether it was actually beneficial. I think that from that study, the one thing that came out of it for me was that you can do it safely and that you can reduce the amount of allogenic blood that you're giving to a patient. And so to me, that's a benefit. And to our OB surgeons and physicians, that was a benefit. I think that it's wise to use a pragmatic approach to focus on patients that are going to be high risk, and those would be ones that you know are most probably going to have active hemorrhage during either their delivery, C-section, or if they're going to need a hysterectomy after delivery. So now I'm going to shift a little bit about just talking about why we might do it and talk about how to set up your program and how we set up our program. And this is my brain. I have a problem. I'm not like Linda Mangiero. And by the way, any questions will be directed to Bill Harris and Linda Mangiero after the session. But it's like when you start thinking about it, it's like, oh, what have I gotten myself into? Okay. The biggest thing, if you're going to start this program, is that you have to have a champion. And we were lucky in that we have a physician champion. So I think for us as the clinician, we definitely need to be involved and be a resource and be mentors and teachers. I don't necessarily advocate or saying that you have to physically do all the work, except I do think that you need to be involved in making sure that you're available to whoever. But definitely identify your medical director, get to know and you probably all do, but if you don't know the pathologist that's over your blood bank, go introduce yourself to this person. Volunteer to get on the transfusion committee at your hospital. Gives us a presence and a voice so that when things happen that impact perfusionists, they know who the perfusionists are. So definitely find your physician champion if you're going to start this program. And then all of us know whatever equipment you're using or decide to use, to do a cost analysis for the hospital to make sure that it's, cost effective for you to add equipment or buy capital equipment. If you have no capital money, which right now Memorial Hermann has no capital money, all your vendors are probably willing to do some kind of tie it to your disposables or put things in at no cost and just upcharge your disposables. So there's ways to get equipment if you don't have capital money. And then again, just re-emphasizing, I think we need to be involved in training and being a resource for your team. I think perfusionists are the people that are trained to do blood management. It's part of our scope. It's part of our education process, and I think we need to be a resource for whomever, whether it's your perioperative blood management technologist or your nurses or your respiratory therapist or your anesthesia techs, whoever in your institution, if you can be a resource for them. And that just adds value to you as a perfusionist, and also that we're making sure that we're doing safe practice. So at our institution, we focused on the OB indications for setting up this program. Placenta previa, are accreta patients. So anytime the patient was going to have a high risk of hemorrhage during delivery. So all accreta patients, all patients that are Jehovah's Witness are included in where we would set up autotransfusion for the OB patient. So we don't do cell salvage for every single C-section, but we do, if these patients are identified, then we actually get a call from the maternal nursing director, and it's pretty scheduled that we'll know this patient's coming. And of course, all Jehovah's Witnesses are included in our program. Going back to the Salvo study, and is it cost effective? The Salvo study actually showed that in the obstetric patient, blood donor transfusion occurred in 3.5% of the cell salvage patients that had an increased risk of hemorrhage. And the control group was no cell salvage. So it was all over the board as far as whether they needed cell saver or didn't need cell saver. What it did show was that a minimal quality of shed blood must be recovered to operate, obviously, to do blood recovery. Otherwise, no shed blood was returned. This study kind of was, I think, skewed the results towards probably not being as beneficial as it could be. And I think if we continue to do randomized multi-centered studies for this patient population to focus on the high-risk patients that are actually at a higher risk of bleeding. I think that we can make it work, and we've made it work at Herman. One way that you can reduce cost or manage whether you're going to collect or not collect is to use the standby option, so that you're just setting up a reservoir and you're collecting, and then you can decide, and we do that on all cases anyway, that you're using autotransfusion for. So that way, if you don't have enough blood to process, then you've not set up a whole machine and wasted all your disposables. And that way, you know in advance that you're going to have a minimum amount of blood to transfuse and process. Several years ago, we use the Livanova systems, we use Electas, and we, several years ago, have been transitioning our fleet of cell saver devices at Memorial Hermann to the Extra. I really like utilizing this piece of equipment for the OB patient. One, your patients are awake, so the suction system on this device is really quiet. So whatever device you decide to use, consider that, because your patients are not asleep, they're awake, and there's not, excuse me, there's not a whole lot of space, and there's not a lot of extra suction systems in your OB suites. Also, with this particular device, we're using the protocol where it's removing like a PFAT protocol, and so it changes the speed of the centrifuge and the duration of how long it spins, so that it can remove more of the fat layer, potential fat. Now, there's not going to be fat, but we use it in that protocol, hoping that we're actually removing more of the plasma component. And we also double wash, and so definitely want to use 2 or 3 times your wash volume that you would for a cardiac case or for a ortho case. Our bolt sizes that we have available at Memorial Hermann are 175 to 225, and that would be a consideration for whatever program you set up as far as how much blood you want to collect, because sometimes the volumes are small, or they can be, excuse me, extremely large. So in our institution, these are the bolt sizes we use. We use a double reservoir, so before the placenta is removed, we collect in one reservoir, and then once placenta is removed and irrigation with saline, then we'll start collecting in a second reservoir. So the first reservoir, before the placenta is removed, that is not processed. To date, we have not been processing that blood. There's discussion with our team if we're going to change our practice, but right now we're very, very conservative how we do this. So I know there's studies in Great Britain, they're actually collecting everything and using the leukocyte depleting filter and processing that blood, but that's, to date at our program, that's not what we're doing. So we're very conservative with what we're collecting. Obviously, your expected hematocrits for your blood that you're going to give back will be comparable to what you would do in the cardiac theater at 50%, and the volume returned to the patient depends on, obviously, your blood loss. The other thing with this particular device, on the device, it'll measure the supernatant removal. So when you start washing, it's actually a little red light on the device, and it starts at 0 and at 90%. So it'll go to yellow, it'll go to green, but it'll actually document or verify your supernatant removal, which we also, just visually looking that the supernatant is clear, but we also like to see that we can actually verify and document that with our QCI program. So we shoot for over 95%, and that's actually been a good practice for us, and to date we've had no adverse reactions from any transfusions that we've given to our patient population. This strategy we're not utilizing right now, but in the literature and papers by Dr. Waters, a way to increase the amount of blood that you could collect is actually saving the lap sponges, soaking them, and then in saline, and then actually sucking that volume back into your cell salvage. So that way you're saving your laps. If you have a major hemorrhage, then you can actually collect that blood and give that blood back. So in our practice, we're not currently doing that. That's something that I'll discuss with our OB physicians. So again, we've been very conservative to date with the blood that we're collecting. But in this study by Dr. Waters, it actually, in his study, said if you get over 20 laps, soaked laps, then you're going to have enough blood to actually process. Now, we all know this already as far as what suction volumes, negative suctions, how to use a suction device, but you're going to be utilizing this in the non-cardiac theater. And so it's it's a good time for us to teach. And so these are strategies just to make sure that the quality of the blood that you're collecting is optimal. And so utilizing these strategies to teach your OB physicians how they need to suck the blood on the field. And they're actually very accommodating to your instruction because they want to follow the guidelines that you've set up with them. So remind them of how to suck blood pooled and not suck skimming. They will listen to you, which is very nice. So this is actually some data from our practice at Memorial Hermann. We started in the fall of 2013, and this data is only for the last 2 years, so we don't have the patient information from 2013 to 15. But out of 42 patients that we've done in the last 2 years, 71% were C-sections, and 29% were C-HIS patients, so C-section with hysterectomy. And like I said earlier, our protocol is that all patients that are that have accreta, placenta accreta, will be put into the target for autotransfusion. 38% of these patients lost more than 400 mils of blood, and the rest was less than 400 mils. And like I said earlier, it's either a lot or it's not very much. So sometimes we get nothing, or we'll get 100 mils, or we'll get 4 or 5 liters of blood. We've had patients that actually have bled, over 5 liters, and you bleed very quickly. The blood comes fast, and so we've been able to actually give back, an average of 700 mils of blood on the patients that actually needed, that warranted enough volume loss that we actually process. And again, for our patients, we don't start collecting until after the placenta is removed. So this blood loss is actually very conservative because there is blood loss prior to the placenta removal that we didn't collect and actually process. And right now we're not actually doing collecting the blood out of the lap sponges either. So that's something that we need to look at our program. The other thing that we're using actually the LipiGuard filter and not the leukocyte depleting filter. We're getting better flow through it, and again, we have had no adverse events with the amniotic fluid removal, so that might be an area where actually some studies could be done in comparing the LipiGuard filter to the leukocyte depleting filter and seeing the quality of the blood and what the collected washed blood level of amniotic fluid or tissue factor is in that blood. I don't know the answer to that, but just so you know, we're not doing what they say. So in conclusion, just thinking about, is this something that can be developed in your institution? One, definitely need a physician champion, an OB physician that is passionate about starting this program.